All right, let's talk about one of the most critical and honestly one of the most feared tests in medicine, the arterial blood gas, or ABG. But forget all that confusion. In the next few minutes, we're going to build a super simple framework that'll have you reading any ABG with total confidence. Let's jump in.
Okay, picture this. Your patient is not doing well. Their vitals are all over the place, and someone hands you this little slip of paper with a bunch of numbers on it. That's not just data, that's a direct message from your patient's body, a distress signal, and you need to translate it, like right now. So let's break down exactly how you do that.
So forget trying to memorize a bunch of confusing charts. We're not going to do that. Nope, we're going to approach this like detectives cracking a case. We're going to follow a simple step-by-step method that works every single time, turning that jumble of numbers into a clear set of clues. Every investigation has to start somewhere, right? And for the ABG, that first, most crucial clue is always the pH. This one number tells you the fundamental state of your patient's blood. Is it tipping too far acidic, or is it too alkaline? So pH is just a measure of how acidic the blood is. And look at this normal range, 7.35 to 7.45. It's tiny. The body is in this constant high-wire act to stay within this incredibly narrow window. So any little deviation, yeah, that's a major red flag. This range is our baseline for the entire investigation.
So our first step couldn't be simpler. It's a fork in the road. You just look at the pH. Is it below 7.35? Then you've got an acidemia. The blood is too acidic. Is it above 7.45? You've got an alkalemia, too alkaline. That's it. Our first clue is already telling us what the fundamental problem is.
Okay, so we know if the patient is acidotic or alkalotic. Now the investigation gets really interesting. We have to figure out why. Where is this problem coming from? Is it the lungs, or is it something going on with the body's metabolic system?
Think of this like we're identifying our main suspects. We've got two primary culprits that can throw the body's pH out of whack. The lungs, which handle our carbon dioxide, and the kidneys, which manage our bicarbonate and other acids. Let's bring them in for questioning, one by one.
Suspect number 1 is PaCO2, the partial pressure of carbon dioxide. This value is our direct window into how well the lungs are working. It's all about how fast and deep we're breathing. And the magic number to remember here is the normal range, between 35 and 45. So, here's the key concept. In the blood, CO2 acts like an acid. So if a patient isn't breathing enough, maybe they're having a COPD flare-up, CO2 builds up and boom, respiratory acidosis. On the flip side, if they're breathing way too fast, like in a panic attack, they wash out too much CO2, leading to a respiratory alkalosis.
Now for our second suspect, HCO3-, which is just bicarbonate. This is the metabolic piece of the puzzle, and it's mainly controlled by the kidneys. Bicarbonate is a base. Its job is to soak up all the extra acid in our system. The normal range you want to keep in your head here is 22 to 28.
And the logic here is really straightforward. Bicarb is a base. So if your bicarb level is low, you're losing base, and the result is a metabolic acidosis. If your bicarb is high, you've got way too much base, and that leads to metabolic alkalosis. Simple as that.
And here it is. This is our master key. This is where it all clicks. You just follow the clues. So let's take an example. Look at that third row. Let's say your pH is low, so you know you have an acidosis. Now you look across at our suspects. Is it because the CO2 is high? Yep. Then you've solved it. It's a respiratory acidosis. You just match the pH with the suspect that's out of line.
But a good detective never stops at the primary cause, right? We've got to dig a little deeper. First, is the body trying to fight back? We call that compensation. And second, are there any other hidden clues we might have missed? Let's find out.
The human body is just amazing. When one system creates a problem, the other one tries to compensate. So if the lungs cause an acidosis, the kidneys will try to fix it by holding onto that base, that bicarbonate. If the metabolic system causes a problem, the lungs will change how fast you breathe to try and compensate. Our job is to figure out if that response is actually happening and if it's enough.
But how do you know if the compensation is good enough? Well, for metabolic acidosis, there's this brilliant little tool called Winter's formula. Now, forget the math for just a second and get the concept. This formula tells you exactly what the PaCO2 should be if the lungs are doing their job properly. It's like a built-in quality control check. So here's how you use it. You take the patient's bicarb, you multiply it by 1.5, then add 8.
That gives you the expected PaCO2, give or take 2. Then you just compare that number you calculated to the patient's actual PaCO2 from the blood gas. If they match up, awesome, the compensation is perfect. But if they don't, well, that's a huge clue that there might be a second problem hiding in there.
Now, when we've specifically diagnosed a metabolic acidosis, our detective work isn't quite done yet. There is one more layer to uncover, a hidden clue called the anion gap, and this is going to help us narrow down what's causing the problem in a big way.
Calculating it sounds way more intimidating than it is. Seriously. You just take the main positive ion, sodium, and you subtract the main negative ones, chloride and bicarbonate. That gives you a number that represents this gap of unmeasured stuff. Then you just compare that result to the normal range, which is about 8 to 16.
And why on earth does this matter? Because the result splits the causes of metabolic acidosis into two completely different buckets. If the anion gap is high, you start thinking about big stuff like diabetic ketoacidosis or DKA, lactic acidosis, or kidney failure. If the anion gap is normal, you're thinking more about causes like losing bicarb from diarrhea. It's a super powerful diagnostic tool.
All right, we have all our detective tools. We know how to check the pH, we know how to identify the culprit, check for compensation, and even look for hidden clues. Now let's put it all together and see how these tools solve real clinical cases.
Let's start with a classic, DKA. Using our system, the pH is low, so it's an acidosis. Why? Because the bicarb is low. That's a metabolic cause. The body's trying to fix it by breathing super fast, so the PaCO2 is also low. That's our compensation. And then, when you calculate the anion gap, it's going to be high from all those ketones. See? The pattern is crystal clear.
What about a patient with a bad COPD flare-up? Again, let's just follow the clues. The pH is low. Acidosis. Why? Well, they can't breathe out their CO2, so the partial pressure of CO2 is high. It's a respiratory acidosis. And you can see the kidneys are trying their best to help out by holding on to bicarbonate, so the HCO3- is up as compensation.
Okay, last case, someone who's hyperventilating from an anxiety attack. Let's run the clues. The pH is going to be high. Alkalosis. And the cause? They're breathing off way too much CO2, so their PaCO2 is low. It's a classic respiratory alkalosis. And the body's response? The kidneys start dumping bicarb to try and even things out. See? The system just works every single time.
So, we've learned how to crack the code. This step-by-step approach gives you the what. Metabolic acidosis, respiratory alkalosis, whatever it is. But the numbers, they're never the end of the story. They're a clue that points you right back to the patient. So the real question is, now that you've solved the puzzle on the paper, what's your next move for the actual person in that bed? Because that's where great clinical care really begins.